I agree. I agree.
Okay, we'll have it at some other time.
Yes.
Thank you, Devabrata,
Thank you,
Bappa,
sir.
and Shuchi. Thank you very much.
Thank you.
The
Thank you, sir.
next,
Thank you all.
next subject is COVID-19 and cardiovascular disease, what every physician should know. This subject will be taken up by Dr. Rakesh Yadav, who is the Professor of Cardiology at All India Institute, and he is the editor of Indian Heart Journal. And to chair the session, we have Dr. M.K. Das, the President CSI, and Dr. Amol Choudhury. He is joining from Bangladesh. Over to you, sir.
Thank you, sir.
Rakesh, can you hear me?
Yes.
I think
sir, your microphone is muted, sir. Rakesh, sir.
Yeah. So
Now,
Rakesh, over to you. You straight away deal with the subject.
exactly. Good.
Okay, sir, I'm clearly audible?
Yeah.
Yes, very
Go ahead.
much.
Okay, sir. Thank you, sir, Dr. Guha, sir, for giving me opportunity. And I think this is a very important talk at present, what every physician should know. And COVID is now becoming, from last 4 or 5 months, there are more than 10,000 publications for COVID. And every 15 days, you are getting something new and old and contradicting the past finding. So what in next 15 minutes I'm going to do overview of basics of COVID and basics of involvement of cardiovascular disease and what every physician should know. We all know that this is a coronavirus disease 2019, and it is known as severe acute respiratory syndrome coronavirus 2, at present declared as pandemic. And at present, there is over 11 virus sequences which are floating. That is very, very important. These 11 mutations which are being detected, and 2 more mutations are being reported. So at present, there is about 13 mutations for this COVID. Now, this is very, very important because it is a single-stranded enveloped RNA virus, and more than 90% of its genome resembles that of bat. Now, this COVID resembles more SARS-CoV-1 pandemic, which was in 2012. It was an epidemic, and Middle East respiratory syndrome. Now, the mortality of Middle East respiratory syndrome was much higher. It's about 30%. And for SARS-CoV-1, which was in 2012, it is more than at present COVID. Now, that is very important thing, that COVID-2 belongs to a beta coronavirus, and it binds to ACE2 receptors to get a cell entry. That is very important because a lot of debates is going on about the ACE inhibitors and ACE2 receptors. So this binds to ACE2 receptor to get entry, and then the spikes activates. Now, this is yesterday data. We have about more than 16 lakh, and today 57 lakhs more added. So we have crossed 17 lakhs, and every day practically more than 50,000 cases are coming. Now, these are the few facts. The last Zero survey says that about 23% of Delhi population has already been affected because they are found to have antibodies in their blood. And in India, because old age is affected only 3%, it's mainly between 30 to 80 years, about 87% population is there. The mean time to symptoms in India is about 5 days. Mean time to death in India is about 14 days. And majority of about 82% has mild to atypical illness, and only moderate to severe illness in 15 to 70% cases. Now, the incubation period varies a lot, from 2 days to 14 days. But in India, its means come about 5.2 days. And the time to pneumonia is about 9 days, and time to CT changes is only 4 days. Even before starting symptoms, you may have a CT chest changes there. Now, this is very, very important because we calculate death rate. What is being projected is a death today versus number of cases today. But actually corrected death rate is the ideal death circumstances for COVID, because if you calculate the cases 14 days back versus death today, because average death takes 14 days, that will be actually the mortality, and it is not 2% or 3%. If you calculate by this formula, it is going to be more than 6%. And this is a daily data. For one symptomatic test positive cases, there are 1 to 20 asymptomatic cases, and which are 20 are untested. It means with every one symptomatic patient, you may have 50 patients who are carrying this virus. Now, it is important that case fatality rate, and it is being described by the Western population that more than 80 years, case fatality rate is more than 15%. Probably this is true in India. I think in our because number of old age patients are less, but however, the fatality rate, if it is more than 80, is more than 30% in Indian series, some of the Indian series. Now, this is a reproductive number which everybody should know, the R0, which is around 3.2, and it ranges from 1.4 to 6.9. And the doubling time at present is about 7.5, and it spreads via human to human. It is basically an airborne disease. It's spread via the droplets. And at present, the consensus is that the surface transmission is much, much less. Fomite transmission is much, much less. And it can enter through your body, through the eyes, through the nose and mouth. And obviously, it is ACE2 receptor which is responsible for that. This virus has been detected even in stool and urine. And the vertical transmission from mother to a child, a newborn child, has been detected in India also, and the first case in Pune is recently being reported. Now, these are the main symptoms. You should always know that any viral symptom can be a COVID symptom, starting from fever, which is about in 70 to 80%, cough in 70 to 80%, only generalized fatigue, expectoration, dyspnea, and lymphopenia. These are some of the important symptoms, and the minor symptoms are sore throat, diarrhea, dizziness, headache, nausea, vomiting. Conjunctivitis occurs in about 13% of the cases. Loss of taste and smell, and it varies from 20% to 60%. And now it's a good thing that if your symptom is loss of taste and smell, the COVID is less serious. And there is a recent analysis which says if you have these symptoms, there are less chance that you are going to have a severe COVID. You may have a rashes on skin also. Now, in severe cases, you may present as pneumonitis and ARDS. Acute coronary syndrome is an important manifestation. The cardiogenic shock because of fulminating myocarditis, and there is sudden cardiac deaths are recently being reported post-COVID. And you can have a stroke, and in our series, we have found that there's more stroke which is occurring during this COVID situation. Now, these are the various comorbid conditions which increases the risk of death during COVID, and it's a very, very important. If a patient is having hypertension and diabetic, the chance of death increases by 12 times. It is a huge fold increase in death if you are diabetic and hypertensive. However, cardiovascular, the cancer, the obesity, and currently the COPD, because it's very prevalent in India, is an important comorbidity in COVID disease. Now, coming to the cardiovascular manifestation. Now, if I have to say, there's three important things when we are going to discuss a cardiovascular manifestation and clinical course of COVID-19 infection. Now, cardiovascular diseases and hypertension are two important comorbidity. First thing is, we should remember it. Severe COVID-19 infection is associated with myocardial damage and cardiac arrhythmia. That is also being reported, and up to 23% patients who are admitted in ICU will have ultimately a cardiac problem. And third important thing, the majority of the drug which is given in treatment of COVID causes cardiac toxicity, either in a form of prolonged QT arrhythmia. So these three important aspects we have to understand as far as physician is concerned and cardiovascular and COVID is concerned. Now, cardiovascular involvement, how it occurs? It may be a direct myocardial injury, and it is basically because of severe pro-inflammatory or inflammatory condition during severe COVID, and hemodynamic changes because of extensive respiratory involvement. If your lung is damaged, obviously you are going to have a right-sided heart failure. So these are two important things by which indirectly myocardial injury occurs. Then how direct myocardial injury occurs? There is acute myocarditis which has been reported. Stress cardiomyopathy has been reported, and possible ACS because of COVID, it is due to atherosclerotic plaque instability. And it is also mentioned that because of this, there is a high chances of thrombotic event. Cardiac arrhythmia and sudden cardiac death, thrombosis, in certain series, they found up to 33% of the patients who are sick, who are in ICU, have pulmonary thromboembolism. So thrombosis is a very, very important part of COVID infection. And contrary to that, there is a lot of bleeding disorder, because thrombocytopenia is one of the important manifestations. There is a lot of bleeding occurs. So thrombosis and bleeding, both are important things in severe COVID infection. And ultimately, heart failure and cardiogenic shock, for which the management and we all believe that if patient goes in cardiogenic shock and heart failure, mortality in COVID is very, very high. This is very, very important, because the SARS-CoV-1 infection, which occurred in 2012, they have seen long-term sequelae, cardiovascular sequelae, in a form of increased atherogenousity, in a form of diabetes, in a form of increased lipid abnormalities. So the acute complication, COVID-19 infection, may also be linked with the elevated long-term cardiovascular risk, which still we don't know, but in near future we can know that how it increases the long-term cardiovascular risk. Now, this is our pathophysiology. I'm not going in detail. Basically, you should know that this need ACE2 receptor to enter into one cell. And all we know, the ACE2 receptors are present in lung, predominantly lung. They are also present in the heart and the blood vessels. And they are basically regulate the angiotensin system. The second important problem with the COVID infection is that cytokine release stop, because there is an increased imbalance of T cell activation and dysregulated release of interleukin 6, interleukin 17, and other cytokines, and this contribute the majority of the mortality in the COVID infection. And we don't know which patient will go in cytokine release storm, which patient will not go. Still, there is a lot of algorithm, but no algorithm has proven to be ideal in this situation. There's another important injury, cardiac injury, which is at present being reported, like hypoxia-mediated cardiac injury, which is an important part once fulminating pneumonitis on ARDS developed in these patients. Now, this is very, very important. The COVID-19 infection is associated with increased cardiobiomarkers. Okay, we have all seen that elevated troponin levels has been found, elevated BNP levels has been found, increased interleukin 6, D-dimer, ferritin, LDL. They all has been found to be increased in the blood during COVID infection. And these are the important issues to management of ACS patients. Now, training of medical and paramedical staffs is utmost important, because we are untrained medical and paramedical staff to tackle the COVID infection. Myocardial injury, which mimics like acute coronary syndrome. There may be actually no acute coronary syndrome, but ECG is showing ST elevation, which may be because of myocarditis. This is very, very important. Lack of rapid test, because of lack of this, we cannot make quick triage of COVID-19 positivity and segregate the patients. Patient may be diagnosed as having this infection during the course of hospital stay. So that is very, very important. Separate CCU and cath labs in COVID situation. We always say that cath lab should be entirely dedicated to COVID patients. Your every interior should be as per guideline. So you should have a dedicated cath lab. You should have a dedicated hospital. Delayed presentation of STEMI. That is because of so many causes. Significant increase door to balloon time. Even the patient presented in a hospital, there is a significant increase in door to balloon time because of a lot of logistic problem. So majority of the physician, and even we recommend that thrombolysis may be preferred even in the hospital where primary PCI facility is available. And you should always know, because we have to give a lot of anticoagulation because of increased risk of bleeding. You should be cautious in these patients when they are admitted and they are being treated. Antiviral drugs. There's a lot of toxicity of antivirus drugs like lopinavir and ritonavir. They prolong QT interval. They all derange the warfarin level. It has been known if you give lopinavir and ritonavir, because it induces a CYP34A, it can increase the efficacy of ticagrelor and clopidogrel. However, there's a report that prasugrel may be more safer when you have an active COVID infection, when you are going for a PCI. Now, these all are, when you are having lopinavir, then statins dose should be minimized. Ideally, you should only give atorvastatin and rosuvastatin because simvastatin, lovastatin has a lot of interaction. The QT prolonged drug should be given cautiously, and there's a lot of debate of SCQ and chloroquine. I'm not going into detail and a depth of these debates, but if you are giving these drugs, a regular monitoring of the QT interval is mandatory. So you should always monitor QT when you are giving these drugs with antiviral medications, and if patient is already in amiodarone and other drugs. As far as ACE inhibitor is concerned, at present, if patient is on ACE inhibitor, do not stop ACE inhibitor. And if other condition like patient is in heart failure, continue ACE inhibitor. But as far as hypertension is concerned, at present, my thing is don't start ACE inhibitor for simple hypertension. I think for COVID period, I will start calcium channel blocker, and a lot of other cardiologists agree on this, that if you have a mild hypertension, if you want to start some medication, I prefer to give calcium channel blocker at present as compared to the ACE inhibitor. Rest if patient is on ACE inhibitor, do not stop it. That is very, very important. Follow up with telephonic and tele healthcare system should be extended. All stable patients you should avoid. I think I will take 2 or 3 minutes more. You should all try to give them a teleconsultation, and now there is an Indian guidelines. You are being protected by giving teleconsultation. There's no legal problem. You can go, you can download this guideline, read it, and implement it. Now, this is very, very important. When you encounter ADV COVID patient, you have to differentiate between 3: confirmed COVID, suspected COVID, and low clinical or confirmed non-COVID, because it will help you in arranging the logistic of your clinic and everything. Primary PCI should be preferred ideally. If you can do it with all logistic, you should do primary PCI. Otherwise, thrombolytic is pharmacoinvasive is a good alternative. For NST-MMI, all patients who are stable, the angioplasty, and that should be deferred till you get a COVID result. And this is a very good algorithm which is given by Cardiology Society of India, how flow chart for reperfusion strategy for acute MI during COVID-19 pandemic. And I think you can download this important guidelines which has been published recently in Indian Heart Journal, and they are very useful for common physician, for acute MI, for heart failure, for echo, and for congenital heart disease. As far as congenital heart disease is concerned, I think it is the management of congenital heart disease is more challenging, and it is compromised because of several factors. And I don't think, and that is very, very important, a Kawasaki-like presentation has been even seen in India also. A lot of child are presenting like Kawasaki-like disease. But all this standard protocol which is followed in adults should be followed in children management. That is very, very important. Do not ignore children. Always follow as it has been followed in adults. Now, this is very, very important. Arrhythmia risk due to QT prolongation. But unfortunately, what happened? Till now, no Tarset pointis is being reported in any literature during COVID. Everybody says it increases significant number of QT prolongation, but till now, no reports that patient is going to have Tarset. But however, you have to be very, very cautious during COVID. Now, these are the basic ECG. ECG has a lot of non-specific changes. The most common is sinus tachycardia. The QT prolongation may be per se because of myocardial involvement, but it can be because of other drugs. There are non-specific STT abnormalities, which is seen in up to 50% of sick patients. Atrial fibrillation is seen up to 10%. S1QT-T3, which is a pulmonary embolism in some series, it is reported up to 8%. Brugada-like pattern and AV block has also been reported because of COVID infection. Now, this is my second last slide. Beside everything, all physicians should know the important socio-economical aspect of the COVID situation. Lack of proper scientific data. Yes, we don't propagate a proper scientific data. There is always confusing scientific data which is prevailing in the internet. So practically, even a physician is confused. Lack of scientific uniform healthcare resources. The poverty, the overcrowding, the poor sanitation, public awareness, life versus livelihood, unnecessary fear, and social stigma with COVID-19 should always be kept in mind once you are discussing COVID to the primary physician. So to conclude my talk, COVID-19 and cardiovascular involvement is a very complex thing. CV disease management in COVID pandemic is also challenging and complex. Poor awareness, knowledge, and proper guideline-based care of both staff and patient is utmost important. So you should not only take care of your staff, but take care of your patient also. If you have no proper PPE, then do not venture for any non-invasive approach. That I always say. If you cannot protect yourself, don't venture. And for COVID, I code, protection and prevention is the only cure. We always say prevention is better than cure. But for COVID, this is my code, that protection and prevention is the only cure. Thank you very much.
Thank you, Dr. Rakesh Yadav, for your beautiful presentation. And I think most of the things you have covered, and definitely we should protect ourselves while treating the patients of COVID with cardiovascular disease. And that's how we can prevent the cardiovascular disease in ourselves. But having said that, could you highlight some of the points related to the happy hypoxia syndrome? Happy hypoxia syndrome, because that's very, very important nowadays because of the higher incidence of sudden cardiac death, which is happening all over the world.
Yes, it has been reported the patients don't have any symptoms, but if you see their saturation, that is coming 88, 89, 90. So this has been reported, but overall, if you go in happy hypoxia syndrome, you will find it that there is some symptoms and the lung pathology is there. So because the CT takes only 4 days, the lung involvement only takes 4 days, some symptoms start after that. So all these patients subsequently develop symptoms of COVID. So that you have raised a very valid question, but all those patients gradually develop symptoms of COVID. But yes, it is known that the saturation is 88 and patient is absolutely asymptomatic. Nothing is there.
Thank you. Can I thank you for excellent presentation of Professor Rakesh Yadav. First, I like to thank the UCD organizers, especially Professor Guha sir, and also there is present CSI President M.K. Dash, because I am the life member of LMA. I think few life member outside India. Among them, I am one since 10 years, I think, and also the legend cardiologist. Thank you from Bangladesh. I like to know that the Professor Rakesh also give a very excellent talk, cover all the things, but in this era, I think it will continue for several years. So every physician must know the basic. What is basic? The pathophysiology of COVID, the contact, the mode of transmission, the change of genetic sequence already covered by the presenter, and also the category of the contact are like this, because we need to deal the patient with COVID in the routine life, I think, after 1 or 2 months after. Then elaborately discuss the COVID impact on cardiovascular disease. All of we know that there is direct impact and also pre-existing heart disease in different levels, ischemic, valvular, congenital, and different. And also like to emphasis on the junior doctors who are the frontline fighter to know how to protect themselves, because in my country we have lost of cardiologists without any COVID hospital, without any dedicated COVID hospital working in the NICVD. In my hospital, we lost our senior professor, Professor Abul Hossain Khan Chaudhary. He was the interventional cardiologist, one of the first 3 professors among my country. So again, I conclude to emphasis on the personal protection. Thank you, sir. Thank you. Thank you. I like to ask one question. I like to ask one question. Rakesh sir.
Yes.
Can we ask any anticoagulant who needs anticoagulant without prior low molecular weight heparin in whom?
You are asking without yes. There is a recent study that oral anticoagulants has been used in serious COVID patients as rivaroxaban 2.5 million BD. There's some studies. So, and you all know that every sick patient required heparin. The low molecular heparin is given practically in all sick patients until there is a bleeding. So there is a recent study which has suggested, though the final outcome is not there, that probably the oral anticoagulants Novec can be used in sick patient of COVID because of they have very high thrombotic risk up to the extent of 33% admitted patients. So yes, you can give it.
Thank you.
Thank you.